Relapsed refractory large cell lymphoma, we typically will divide these patients into two sort of separate categories. The more troublesome of these two are the patients who have primary refractory disease. These are patients who relapse from frontline therapy within 1 year of treatment. Because of these patients' sort of historical outcomes being very resistant to chemotherapy, not necessarily responding to salvage therapy or autologous stem cell transplantation, these are patients who have been, as of more recently, directed to a CAR T therapy with the approval of Axi-cel and Liso-cel in second-line large cell lymphoma. Sort of with the utilization of these agents, we have been able to improve the overall response rate and overall survival of these patient populations. I'll bet, there's still about half the patients who will progress after this treatment with these CAR T-cell therapy. After failure of CAR T-cell therapy, it does present some of an issue. So those who are primary refractory to CAR T, we have some early data from the Spanish group that suggests that these patients are very difficult to treat and may not necessarily be salvageable even with bispecific CD20, CD3 antibodies. In this patient population, it did look like maybe chemotherapy treatment with bendamustine and polatuzumab may be a more effective treatment option for some of these patients. Those who are relapsed, meaning they get an initial response to CAR T and relapse thereafter, those patients do appear to be patients who probably will respond to the CD20, CD3 bispecific antibodies, and these are patients who we probably can salvage and probably hopefully resurrect some of the T cells, which are hopefully still available from the CAR T cell therapy. Thereafter, if a patient who does not respond to a CD20, CD3 bispecific, there is a sort of triad of agents, and probably one that will be approved pretty soon. So we have Loncastuximab tesirine, which is a CD19 drug antibody conjugate. There is rituximab, polatuzumab, and bendamustine, which we previously discussed. There's also the option of lenalidomide and tafasitamab, although that's not really been evaluated in patients with primary refractory disease. And then more recently at the ASCO meeting, we had Echelon 3, which looks at R-squared and Brentuximab, which appeared to have an overall survival benefit against R-squared. So this will likely also be another option available for these patients. If we look at patients who are relapsed, meaning those relapsed more than a year after initial treatment, these patients do have quite a bit more options. Now, in certain situations, a patient isn't transplant eligible. There's still the option of Liso-cel for a CAR T-cell therapy, but these are also patients who seem to respond very well to lenalidomide and tafasitamab from the original LMIND study, with long-term data suggesting some of these patients could potentially be cured with this therapy. And then we can still run down a sort of list of some typical therapies that can have salvage chemotherapy and auto transplant consolidation. R-Pola-BR, Loncastuximab tesirine, and again, this is also a population where the new Echelon 3 data could suggest that maybe R-squared and Brentuximab could be an option for this patient population. And there will likely be other agents that can be utilized in this situation, including the bispecific antibodies, which have an indication in third line and beyond.